all. Good evening and good morning to all my friends. Myself, Dr. Anuradha Chougule, consultant at Tata Memorial Hospital and chair professor at MUHS. Thank you, Thermo Fisher team, for inviting me as a speaker on this Oncomine World 2023. These are my disclaimer. The idea of precision oncology of cancer has emerged as a powerful clinical strategy with the objective of targeted therapy. However, the liquid biopsy concept is not new. It was way back identified in 1948 in the detection of the cfDNA in human blood. Then thereafter in 1977, a high concentration of ctDNA was extracted in the cancer patients. Then going after in the 1994, a first mutation of RAS was identified in the ctDNA of the colorectal cancer patient. But thereafter, it did not look back, but this technology went on evolving, and you can see over here in 2016 there was an FDA approved for the liquid biopsy testing on the cobas for the EGFR testing in non-small cell lung cancer. And now in 2019 the FDA has approved again the TheraScreen PIK3CA RGQ PCR kit for the patients with HR positive and HER2 negative in breast cancer patients. So liquid biopsy has nearly 3 different variables. You can see over here, you can do either the circulating tumor cells. These are the cancer cells which are released from the primary tumor mass into the bloodstream. Then you get to see the circulating tumor DNA, that is the city nucleic acids, which also is comprised of miRNA, mRNA, and long non-coding RNA as well. And exosomes, which are still into the research, they are the small membrane-derived vesicles, contains various molecules such as signal protein, microRNA, lipids, and exodermal DNA. So you get to see the CTC, which is still into the research, not being popular into the clinic. But however, with the ASCO guidelines 2016, the ctDNA has got approved to do the various molecular profiling for the patients in various cancer diseases. So you need to know that this tumor tissue has certain limitations because of its intra and interspatial tumor heterogeneity. So you don't get to see at times the perfect or the real tumor-derived biopsy. So you may miss the mutations, you may get the erroneous results. There can be either false negative or false positive. So other than if you can bypass the tumor biopsy, you can do the testing on the cytology samples as well. So these 3 sample types can be used for different molecular profiling. Other than cytology, you can use the plasma, which has become the popular. It is likely to be the preferred to be the sample option, and as you can get to store this plasma once separated, and you can collectively do the profiling of the patient. Other than plasma, you can also do in the cerebral spinal fluid. You also use the peritoneal fluid, ascitic fluid, and also on the serum, urine, and many other types of body fluids. So as you can see, the relevance of liquid biopsy, the multiple uses, like it can be used for the asymptomatic detection, prognostication and diagnosis, treatment selection, residual disease testing, detecting the recurrence, and monitoring of the ongoing therapy, which is very, very important because it is as a non-invasive procedure. You can do monitoring at every 3 months of the interval, and also the monitoring the repeat therapy. So you can see the efficacy of the liquid biopsy in performing into the clinic. So as you all see, the liquid biopsy definitely reduces the turnaround time, because there are so many variables when the oncologist advises for the tissue biopsy. It goes, once it is advised, it goes to the CT guided biopsy or some bronchoscopy, or the pulmonologist also goes for the resection of the biopsy. So once the surgery is done, it goes to the histopathology department. It has been identified, the morphology is done, and then thereafter it is sent to the outsourced lab for the molecular profiling. But however, you can bypass these steps by doing the liquid biopsy testing, and it really reduces your turnaround time. But however, if the liquid biopsy gives a negative results, you need to do the tissue biopsy for sure to avoid a false negative results. There are various approaches for the mutation analysis of the ctDNA. For the single gene testing, you can use the real-time PCR methods like qPCR, digital PCR. But if you want to do the whole genome profiling, but for the targeted panels or for the whole exome, whole genome sequencing, so definitely next generation sequencing is the best platform to be opted for, because it has a high sensitivity which goes up to 0.1%, or you can also consider 0.01% as a positive in the canonical mutations. So this is the use of NGS in the liquid biopsy testing. I've already mentioned about this, that targeted next generation sequencing based on this molecular tagging technology allows the considerable improvement in the approaches of cfDNA analysis. cfDNA represents the most stable genetic material and accessible source in the liquid biopsy field, and its assessment allows the detection and monitoring of cancer-specific genomic alterations in the blood. So the ctDNA testing for the determination of the driver and resistant mutations have entered the daily practice of clinical laboratories. As you can see over here, the T790 mutation is an example where you get an acquired resistance when the patient is on the targeted therapy. So even the presence of below 1.1% of the mutation allele frequency in the blood is also considered as a true positive, because it doesn't lower the specificity while doing the detection. So this is in short an overview of the liquid biopsy for the NGS testing. So you collect the peripheral blood in the EDTA tube or in the STREC tubes, then you separate out the plasma, submit it to either it can be a bead-based technology or it can be a column-based technology. Once the plasma is separated, you can do the library preparation of the desired targeted gene panel which you are interested in, and then with the quantification with the qPCR assay, or you can do the tape station where you get to see the amplified product, which exactly indicates that your libraries have worked. Once the libraries have done, you do the multiplexing, and by pulling the samples which are barcoded, and then they can be loaded on the NGS platform, and then there you get to see the performance of on the NGS platform as well. Once the raw material is out, it goes for the bioinformatic analysis, and then they are correlated with the databases available on the Google platforms. So you can you can get to see the interpretation of the results once the data is out, and it can be clinically correlated. However, as you all know, it's a very you get to have a very low yield of ctDNA at times. So you require a very high sensitivity technology. So as the tumor content decreases, the test sensitivity of the limit of mutation detection should also increase to ensure all patients are correctly genotyped. So lower the sensitivity, lower the yield of the ctDNA, you need to have a higher technology for the detection. So this is our 7 gene panel which was established in our laboratory, and you can see we looked for the EGFR, MET exon 14, HER2 exon 20, ESR1, where we sequenced at an average coverage of around 99,000. across all samples, and the data was analyzed in Clinome tool developed in-house at Actract TMC. So this is our bioinformatic in-house technology where we do analysis of all the samples. And then further, we looked for the orthogonal testing, that is the reflex testing. And you can see over here, all the results were matched with the real-time PCR method. So it shows how good is the concordance between the real-time PCR and the NGS technology. So definitely the NGS platform is useful to identify the various mutation. Further, in ASCO 2016, the ASCO documented that the liquid biopsy can be used as a guide treatment decision for the patients with advanced solid tumor. So this was very much appreciated into the clinic by all the oncologists, because this helped in getting the reports earlier and also in the risk stratification. Here you can see how in the lung cancer, the recommendation of ctDNA is useful, because if the tissue is an issue because of the insufficient, then you can use the liquid biopsy, and you can also use it for the progression of the recurrence if the EGFR TKI of a T790 mutation is identified. If biopsy is not possible at the baseline itself, you can very well go with the liquid biopsy, whether it can be a plasma based, and in the metastasis you get to see the ascitic fluid, cerebral spinal fluid, the pleural fluid, where you can definitely use it for the genomic profiling. In breast cancer, yes, if there is a HER2 positive and HR positive and HER2 negative, then the PIK3CA mutation has become popular in identifying through the liquid biopsy testing. And this has definitely helped in the prognostication and therapeutic decision by using the PARP inhibitors for the patient. So, the clinical utility of ctDNA analysis in advanced solid tumors helps in risk stratification, in response assessment, and resistance monitoring. As you can see over here, if the patient is resistant, you can very well identify which acquired mutations, resistant mutations are there by doing the genomic profiling, and one can definitely change to the systemic therapy as well. So this was one of the first paper when we started the liquid biopsy testing in Tata Memorial Hospital, and we looked for the concordance of these results by doing the reflex testing. And you can see over here, there was nearly a 99% specificity and sensitivity seen in the both the liquid biopsy as well as tissue biopsy samples. So a total of 163 NSCLC cases were included for the validation. So ctDNA was validated using deep sequencing with custom designed bioinformatic methods that could detect the somatic mutations at allele frequency as low as 0.01%. So this indicates that you can very well use the liquid biopsy if in the clinic, but however, if you get the negative results on the liquid biopsy, you really need to go back for the tissue biopsy testing again. So this case study is that of a patient with the metastatic castration-resistant prostate cancer with the progression to soft diffuse bone and regional lymph nodes, who was treated with the abiraterone and plus prednisone with the excellent prostate-specific antigen response. However, at the time of progression, the NGS analysis was done with the ctDNA testing by using the commercially available test, and it was identified a check to mutation and a BRAF V600E mutation, which later is being exceedingly rare in the prostate cancer because we get to see the BRAF V600E in a melanoma patient and very rarely seen in the prostate cancer. So this totally diverted the line of treatment, and this helped definitely for the patient betterment by treating him with the related targeted inhibitors. The potential clinical application of cfDNA in advanced prostate cancer helped in making the predictive marker. So the HRR gene mutations are also associated with the increased sensitivity to PARP inhibitors and to platinum therapies. The detection of HRR gene mutation in plasma is highly correlated with the detection of this mutation in molecular analysis of biopsy tissues from metastasis. So to identify novel mechanism of resistance, cfDNA analysis has allowed to identify the methods underlying the acquisition of resistance to the PARP inhibitors via the selection of mutations that revert the open reading frame of BRCA2. So the sequential analysis of cfDNA using NGS has identified 2-point mutations in the AR associated with the resistance to treatment, which indicates the 2105 to T to A, that is at the point of 1702H mutation. So another point mutation was also identified when we went through the mechanism of when we went through the NGS testing for this particular prostate cancer patient. So this is how the prognostic relevance of the of changes in cfDNA concentration following the PARP inhibitors. And definitely you can see over here, the cfDNA concentration falls after 8 weeks of olaparib, which correlated with both at the progression-free survival and the overall survival of the patient. So with this Kaplan-Meier plot, it shows that differences in the PFS and the overall survival based on the presence or absence of a more than 50% fall in total cfDNA concentration after 4 weeks and after 8 weeks treatment with the olaparib. So these are the various advantage of doing the liquid biopsy. It's just not the point mutation, but also you can look for the chromosomal rearrangements, copy number aberrations, insertions, and deletions. Additional features characterized for the ctDNA are specific, where you can see the epigenetic aberrations like methylation pattern or different DNA fragment at length. So the information on tumor-specific transcription can also be obtained from the ctDNA analysis by reading the internucleosome depth coverage. In virus-induced tumors also, like for example, the Epstein-Barr virus-related nasopharyngeal carcinoma or HPV-related head and neck tumor, the quantitative assessment of the virus sequences have a diagnostic validity. So these are the advantages of doing the liquid biopsy. So there are different methods, like you can do by the gel electrophoresis and electron microscopy reveal that the plasma DNA is not randomly fragmented. So approximately the size of ctDNA is around 160 base pair size. The length of the cancer-derived cfDNA molecules are more reliable than those of the wild-type cfDNA, which ranges from 30 bases smaller to 47 bases larger. So low-pass WGS, that is whole genome sequencing approach, has definitely helped able to analyze the minute amounts of the cfDNA as well. So the ability to extract and analyze small fragments of cfDNA therefore appears to be a critically important parameter in the detection of ctDNA. cfDNA size profiling can reveal the tissue source of cfDNA by using the tape station method. So if you have done the meticulous extraction of the cfDNA, you get to see a single peak without no genomic contamination. And this is very essential to avoid. Well, if you see the genomic DNA contamination, we need to purify the sample again to get the genomic profiling of the patients based on the liquid. So these are some of the representative concentration of the ctDNA which have been in different samples. And you can see if you have meticulously, you have the correct concentration, and with the single peak of 170 base pair size, you can really get a good yield of libraries. So the importance of the stepwise extraction is very important. A low concentration of nucleic acid extracted could also give good yield of ctDNA, and you can perform the library preparation and you can do the genomic profiling on the NGS as well. So but however, there are certain challenges associated with the mutation detection in cfDNA. You need to look for the concordance between tumor and plasma, generating a false negative and false positive results in ctDNA analysis, because the false negative results might be explained by the low volume of plasma yield from a typical blood sample of 10 ml, which limits the total number of available genomic copies to be analyzed. Tumor fraction of cfDNA varies between cancer types as well as between patients affected by the same cancer type patient. However, it also depends at what point of time the blood sample was collected, whether it was very close to the chemotherapy or whether it was at the baseline, because if the patient is exposed to the chemotherapy, then there are chances of getting low yield of ctDNA. So even at the metastatic stage, some patients can yield a low amount of ctDNA if the patient is on treatment. Of course, then there is another challenge, that is the germline variant shed from normal cells and during the clonal hematopoiesis. So as mentioned earlier, you need to look whether if the patient shows for the TP53, so we need to identify whether this mutation is coming through the germline or whether it is a somatic mutation, because that will definitely give a different line of treatment for the patient. So identification of cDNA has proven challenges due to the prevalence of the copy number variation in the healthy population of the patient. So solutions, how to overcome these challenges? You can do the ultra-deep sequencing method, which can lower the percentage of the false negative and are currently under evaluation across different cancer types. So the size selection of cfDNA fragments or the choice of an alternative method for library preparation like single-strand DNA libraries for NGS are additional solution. Thereafter, the comparison of paired tumor and plasma samples represents an important prerequisite to evaluate the diagnostic accuracy of analytic platforms, especially for the variants with the allele fractions that are close to the limit of detection. This is a very, very important point to be remembered. The low predictive positive values were mainly associated with the variants when an allele frequency below 1% and could be explained by technical factors like limited sensitivity, bioinformatic filtering of the data, or even plain error of identification. As mentioned earlier, germline contamination integrate white blood cells DNA as control when applying ultra-sensitivity ctDNA sequencing methods. So currently, CNA in cfDNA can be detected using low coverage 0.1x sequencing of the genome followed by normalization algorithms, and this approach necessitates a cfDNA fraction above 5% to achieve good specificity and sensitivity. So whether the CNA detected in plasma are representative of the tumor tissue is still a subject of investigation. However, indeed, the data obtained over the past 2 years have shown that plasma genotyping using hybrid capture NGS technology can reliably detect ALK or ROS fusions in SC patients, although these results need to be confirmed in larger patient cohorts, or you can use some reflex testing like IHC or FISH technology. So, there are always the pros and cons for each technology. So going for the pros, can tissue biopsy be replaced by liquid biopsy? The answer is no, because you cannot identify or you cannot diagnose the morphology or the origin of the tumors by doing liquid biopsy. However, whenever the tissue biopsy is an issue, it can be replaced by the liquid biopsy to look for the genomic profiling, for risk stratification, for monitoring the longitudinal serial dilution of the residual disease as well. So coming to the conclusion, like as liquid biopsy is an alternative to the tissue biopsy and can play a major role in not only in lung cancer patient, but also now it is getting popular in various types of cancer patients like colorectal and breast cancer patient. New biopsy is required when the patient is in progress, but however, it determines the resistant mechanism. So rebiopsy is a challenge in lung cancer patient. If you compare the tissue versus liquid biopsy, they are highly concurrent. However, you get to see the 30% false negative results which are reported. So the clinical utility of the liquid biopsy has been established in several clinical trials. You can use the monitoring of this molecular resistance in tumor is possible only through liquid biopsy. So there are certain dynamic changes in disease molecular profile and can be determined by liquid biopsy. However, it requires a highly sensitive and validated method to correct the genotype of the tumor. Digital PCR, definitely it is useful in monitoring the copy numbers for a single gene testing. I would also like to mention that this comprehensive profiling of therapy selection at diagnosis or progression is very useful in liquid biopsy. It identifies the driver alterations. It also captures the intra and intertumoral metastatic heterogeneity. So the presence of biomarkers, response and resistance can be very well performed by the liquid biopsy. The rational combination therapies also can be used for the liquid biopsy if you get the compound mutations by doing the targeted gene panels. So it is definitely a non-invasive procedure, and you can do the longitudinal monitoring of the patient. So coming to my last slide. So definitely liquid biopsy is a boon in the clinic. Cancer is curable if detected early, and if not, cancer is manageable if monitored routinely through the liquid biopsy technology. So the liquid biopsy provides a ray of hope for the patients as well as for the clinicians for them, which becomes easier to treat with the targeted therapies. Thank you so much.